Welcome to the deep dive. Today we're tackling a condition that might be more common than you think. Fibromuscular dysplasia, or FMD.
Exactly. And for this, we're diving into Rutherford's vascular surgery and endovascular therapy, 10th edition. So a really solid medical and surgical perspective here.
Yeah, and what's so striking about FMD, isn't it, is that it affects the arteries, but it's not the usual things we think about, like plaque or inflammation.
Right. It's this proliferative condition. The artery walls thicken because of cell overgrowth, and honestly, the why is often a bit of a puzzle.
So our mission today is really to get a handle on what FMD is, its different forms, and importantly, how vascular specialists actually manage it.
We want to unpack the key aspects for you.
It's interesting, looking back, it was first really described back in 1938, seen as this quite rare cause of high blood pressure coming from the kidneys, renovascular hypertension.
And it had that very distinctive look on imaging, the string of beads, very visual.
Very visual. But what's intriguing now is that, well, while it was thought to be rare,
The thinking is shifting. Evidence suggests it might actually be more common than we initially thought.
okay, so let's get down to basics. What exactly is FMD? What's happening in those arteries?
Well, at its core, it's a disease where the muscular layer of the artery wall starts to proliferate. You get more cells than usual,
And crucially, as you said, it's idiopathic, no known cause.
right? Idiopathic, non-atherosclerotic, so no fatty plaques and non-inflammatory. Those are key distinctions.
Is there any family link? Does it run in families?
There seems to be, yes.
Hmm.
In maybe up to 10% of cases, there's a familial tendency. Suggests genetics are playing a role somehow.
Okay. And it mainly hits the middle layer, the media.
Primarily the media, yes. Especially in those medium-sized arteries. Think renal arteries going to the kidneys.
And the internal carotids up to the brain, critical arteries.
Absolutely critical. But it's not just limited to those.
Ah, right. I remember reading it. It can pop up almost anywhere.
Pretty much any artery in the body, yeah. Rutherford's has a table, table 143.1, that actually lists frequency based on the U.S. registry data. Renal and carotid are common, but you see it elsewhere too.
And who does it typically affect? Is there a pattern?
There is a very strong pattern. It overwhelmingly affects women over 90% of cases, and typically diagnosed between, say, 20 and 60 years old.
But not exclusively?
No, definitely not. Men can get it, older people, even children. It's just much less common in those groups.
So the symptoms someone experiences really depend on which artery is involved.
Precisely. We usually talk about FMD based on the affected artery. So if it's the renal arteries.
You're often looking at hypertension, high blood pressure.
Exactly. And if it's those extracranial, carotid, or vertebral arteries supplying the brain.
Then you might see things like headaches, maybe migraine type.
Yes. Headaches, pulsatile tinnitus, that ringing or whooshing sound in the ears that pulses with your heartbeat.
Ah, that sounds annoying.
It can be very distressing. And, more seriously, TIAs, transient ischemic attacks, or mini strokes, and even full strokes.
Okay, so we have a picture of what it is and where it happens. But the big question, why? What are the theories on the cause, the pathogenesis?
Yeah, the why is the tough part. There's no single smoking gun. Rutherford's talks about several proposed factors, both environmental and genetic.
Given the huge female predominance, hormones must be high on the list of suspects, right?
They absolutely are. It strongly suggests a hormonal influence, but honestly, the exact connection isn't pinned down.
So not straightforward.
Not really. For instance, one study noted more women with FMD had high blood pressure during pregnancy than you'd expect in the general population. But things like how many pregnancies they had, or whether they used birth control pills or hormone therapy, those didn't seem to correlate. So it's suggestive, but still murky.
What about the idea of ischemia within the vessel wall itself? Something about the vasa vasorum.
Ah, yes, the vasa vasorum, the tiny blood vessels that actually feed the artery wall. It's a fascinating theory.
How does that work?
Well, arteries like the renal and internal carotid are long with few branches. They might have fewer of these vasa vasorum.
Okay.
The idea is that the normal stretching and movement these arteries undergo could injure these sparse nutrient vessels. That leads to ischemia, lack of oxygen in the artery wall.
Which could then trigger the FMD changes.
Potentially, yes.
Yeah.
It's a plausible mechanism. And it might even explain why the right renal artery is affected more often.
Because it's longer?
It's typically longer than the left, yeah. Makes it potentially more susceptible to drooping or apoptosis, which is also seen more in renal FMD patients.
Interesting. And vasospasm. Spasms within the artery.
That's another piece. Spasms could also contribute to that ischemia. And supporting this, Lab studies and vitro work have shown that cyclically stretching arterial cells can actually increase production of collagen and other matrix substances seen in FMD.
We can't ignore lifestyle factors either. What about smoking? Is there a link?
A significant one, unfortunately. Smoking is much more prevalent in FMD patients.
And it makes it worse.
It seems to. Smokers tend to have more severe disease. The U.S. registry data showed, 37% of FMD patients were current or former smokers. That's compared to about 18% of U.S. women overall.
Wow, that's a big difference.
It is. But how smoking contributes? The exact mechanisms we still don't fully understand.
Okay, let's dig a little deeper into genetics. You mentioned a familial tendency earlier.
Right. The fact that we see FMD in siblings, even in identical twins, is strong evidence for a genetic component.
What kind of inheritance pattern are we talking about?
The suggestion is often autosomal dominant, but with incomplete penetrance. Meaning you only need the gene from one parent. But even if you have it, you might not actually develop FMD, or maybe you only get a very mild form.
So it doesn't always show up, even if the gene is there.
Exactly. There was a French study where 11% of renal FMD patients had a sibling with it. The U.S. registry found about 7% incidence in relatives.
And those relatives sometimes had other issues, too.
Yes. Higher rates of stroke, aneurysms, sudden death. It raises the question, could they have had undiagnosed, maybe minimally symptomatic FMD?
It makes you wonder.
And finding subtle carotid artery changes in patients known to have renal FMD also points towards a systemic, possibly genetic link.
And it's probably not just one gene causing all this.
Likely not. It seems to be a complex genetic picture. Researchers have found links to variations in the ACE gene, for instance, and even some HLA associations like HLA-JW6.
HLA? That suggests an immune system connection.
It hints at a possible autoimmune component, yeah. It's an active area of research trying to map out the specific gene patterns involved.
Lastly, on causes, are there other medical conditions often seen alongside FMD?
There were a few associations noted, things like Ehlers-Danlos syndrome type IV, a connective tissue disorder affecting blood vessels.
Okay.
Also pheochromocytoma, Marfan syndrome, Alport syndrome, and even Takayasu arteritis, which is an inflammatory vessel disease. So some overlaps exist.
Right. So putting it all together, diagnosing FMD sounds like it could be quite challenging.
It definitely can be. And a really crucial point is that just finding an aneurysm or a dissection or even just a tortuous, twisty artery, that alone isn't enough for an FMD diagnosis.
You need the stenosis, the narrowing.
You need evidence of stenosis, yes.
Yeah.
Either in one spot focal or in multiple spots multifocal. Without that characteristic narrowing pattern, it's not FMD.
And when FMD is suspected, what else do doctors need to consider? What's in the differential diagnosis?
Several important conditions need to be ruled out. Neurofibromatosis type 1, vascular Ehlers-Danlos, again, Williams syndrome.
These are mostly genetic conditions.
Many are, yes. And various types of vasculitis, those inflammatory vessel diseases. Each has clues doctors look for, like skin changes in NF1 or specific facial features in Williams syndrome. Genetic tests can help too.
You mentioned FMD is typically non-inflammatory. How helpful is that in telling it apart from vasculitis?
It's usually a key differentiator. In FMD, you typically don't see the systemic signs of inflammation like anemia, low platelets, or high inflammatory markers in the blood that you often find with vasculitis.
But not always clear-cut.
Not always. Sometimes large vessel vasculitis can present without those classic inflammatory markers, making it trickier. You really have to look at the whole clinical picture, and sometimes tissue samples are needed.
Okay, let's talk classification. You mentioned the imaging, the angiography is key now.
Yes, the approach has shifted. While we used to classify based on microscope findings histopathology, the focus now is really on the angiographic appearance. The American Heart Association system from 2014 is widely used.
And that breaks it down into two main types.
Primarily, yes. Multifocal FMD and focal, or sometimes called unifocal FMD.
Multifocal is the string of beads.
That's the one. The classic appearance, like beads on a string, with multiple narrowed areas and little bulges in between. It's the most common form.
And focal.
Focal is just a single, smooth, narrowed area. Interestingly, focal FMD tends to show up a bit differently. Less female predominance, often younger patients.
And better treatment outcomes, you said.
Generally associated with better outcomes after treatment compared to multifocal, yes, both short and longer term. But this angiographic system isn't really used for kids.
Was the old tissue-based classification useful at all? Does it tell us anything?
It does give more detail about which layer of the artery wall is affected, intimal, medial, or adventitial. Medial fibroplasia, affecting the middle layer, is the most common pathologically.
And that usually corresponds to the string of beads look.
Often, yes.
Yeah.
The microscopic findings tend to correlate with the angiographic ones, and it reminds us that things like aneurysms or dissections are secondary events, complications happening because of the underlying FMD changes.
Got it. Let's zoom in now on one of the most common sites, the renal arteries. FMD there.
Right, renal artery FMD. Hugely important. It's the second leading cause of renal artery stenosis overall, right after atherosclerosis.
But number one in younger people.
Exactly. It's the most common cause of renovascular hypertension in younger individuals, especially Caucasian women, often in their 20s to 40s, who might otherwise have perfectly healthy kidneys.
How common are we talking? You mentioned maybe more prevalent than thought.
Symptomatic renal FMD causing stenosis is estimated around 0.4% of the population. But if you screen potential kidney donors, people without symptoms, you find it in maybe 4%.
So likely underdiagnosed.
Very likely, yeah.
Yeah.
No easy screening test. And diagnosis can happen across a huge age range, infancy to late 80s, though 15 to 70 is most typical.
One side or both.
Can be either, bilateral or unilateral. And if it's just one side, the right is more commonly affected.
And it's definitely something to suspect with hard-to-treat hypertension.
Absolutely, especially resistant or malignant hypertension. FMD might account for up to 10% of all renovascular hypertension cases.
And these patients often look different from typical atherosclerosis patients.
They do. Younger, fewer traditional risk factors like smoking or high cholesterol, less likely to have plaque elsewhere, mostly diagnosed in whites.
And often affects multiple arteries.
That's a key point. Many patients have FMD in more than one arterial bed. Studies like Arcadia Palol really highlighted this, finding undetected lesions and complications, which argues for considering whole-body imaging once FMD is found somewhere.
It's a big deal in kids, too.
A very important cause of hypertension in childhood. Maybe 8–10% of all pediatric hypertension, and a much bigger slice of secondary causes. It's the top cause of pediatric renovascular hypertension in North America and Western Europe.
So how does renal FMD actually cause the high blood pressure? What's the mechanism?
Those multiple narrowings reduce blood flow to the kidney. The kidney senses this low perfusion.
And flips a switch.
Essentially, yes. It activates the renin-angiotensin-aldosterone system, the RAA system.
Which raises blood pressure.
Right, through fluid retention and vasoconstriction. And over time, other factors kick in: endothelin-1, local RAA activation of the kidney, structural changes in arteries, oxidative stress, making the hypertension stick.
But maybe less inflammation involved than with atherosclerosis?
That seems to be the case. And while the reduced flow can lead to kidney damage, ischemic nephropathy, it tends to be less significant in FMD compared to atherosclerosis. The link between stenosis severity and perfusion seems more direct, suggesting it's primarily renin-driven hypertension.
And the other kidney can suffer too, just from the high pressure.
It can, yes. If kidney function starts declining in someone with known unilateral FMD, you have to wonder if the other side is now involved, or if there's another kidney issue.
What happens if renal FMD isn't treated? Does it just keep getting worse?
Generally, progression seems slower than with atherosclerotic stenosis. But it can progress. Maybe a quarter of asymptomatic patients develop hypertension within 4 years. Angiography shows worsening in up to 40%.
Though that might be an overestimate.
Could be, yeah, since we don't routinely reimage people doing well. Kidney shrinkage and function loss can happen, but less often than with atherosclerosis. Aneurysms and dissections, though, fairly frequent complications.
But complete blockage is rare.
Very rare. As are kidney infarction, severe kidney failure, or the FMD spontaneously getting better.
What clinical clues might point towards renal FMD?
Sudden onset or difficult to control hypertension is a big one. Always think secondary causes.
Like FMD.
Exactly. An abdominal brute, that whooshing sound over the belly, especially if it's off to one side, is suggestive.
What else?
Severe cases, maybe bilateral disease, can cause flash pulmonary edema, sudden fluid in the lungs, sometimes with kidney failure, can even mimic a heart attack.
And the lack of typical atherosclerosis risk factors is another clue.
Yes, in a younger person especially, hypertension without the usual risk profile should make you think FMD.
So when should doctors actively screen for secondary hypertension causes like FMD?
Key indicators include needing multiple, like more than 3, blood pressure meds, sudden worsening of control, onset before age 50, low potassium levels, that abdominal brute we mentioned, or unexplained pulmonary edema. Rutherford's box 143.1 lists these nicely.
And the actual diagnosis, how is it confirmed?
Same initial tools as for atherosclerotic disease, Doppler ultrasound, MRI, CTA.
But they can miss it.
They can, especially if it's in the smaller branch arteries inside the kidney, which happens in maybe 20–25% of cases. MRI CTA see down to about 2 millimeters, but distal resolution is limited.
Is MRI CTA better than ultrasound?
Generally, yes, especially contrast-enhanced MRI CTA. But the gold standard, especially for those tricky branch lesions,
Is still traditional angiography.
intra-arterial digital subtraction angiography, yes.
Okay.
It gives the clearest picture, but it's invasive, so usually reserved for when the findings will definitely guide treatment.
And during angiography, they can measure pressure.
They often do. Measure the pressure gradient across the stenosis, a mean gradient over 10 millimeter Hg, or a renal to aortic pressure ratio below 0.90 suggests it's hemodynamically significant and might respond well to intervention.
Okay, so once it's diagnosed, what are the treatment options?
3 main paths: medical management with drugs, endovascular treatment like angioplasty, PTRA, or open surgery.
And which is best?
That's where it gets a bit controversial. We lack large, long-term randomized trials directly comparing them, and predicting blood pressure response after fixing the stenosis can be tricky.
So when do you lean towards intervention, endovascular or surgery?
Usually for uncontrolled hypertension despite meds, or if patients can't tolerate the drugs, or if kidney function is declining due to the poor blood flow.
And if managing with meds alone?
Close monitoring is key. Regular blood pressure checks, kidney function tests. Some also track kidney size with ultrasound. If it shrinks by a centimeter or more, that might push towards revascularization.
Let's talk medical treatment first. What drugs are used?
Standard antihypertensives, ACE inhibitors, ARBs, beta blockers, calcium channel blockers, diuretics. The goal is usually BP below 14E90, maybe lower for diabetics.
What about blood thinners?
Antiplatelet agents like aspirin are often considered reasonable even without symptoms because of the potential for clot formation or emboli in FMD.
And statins? Or stopping birth control pills?
No clear evidence they provide specific benefit for managing the FMD itself.
Okay, now endovascular PTRA. You said it's often the first choice for renal FMD. Why?
Primarily because the main goal is usually blood pressure control, and progressive kidney function loss is less common than in atherosclerosis. PTRA often gives really good results for hypertension in FMD.
Can you walk us through the PTRA procedure? What's involved?
Technically, it's similar to treating atherosclerotic lesions. Very thin guide wires, 0.014 or 0.018 inch, are used carefully to minimize vasospasm.
Access is usually from the groin.
Mostly femoral access, yeah.
Yeah.
Radial or brachial is rare. Guiding catheters usually get you there, even though the right renal artery might take off a bit higher. The FMD lesion is typically mid-artery, so the origin from the aorta is often clear, which helps.
Heparin is standard.
Yes, systemic heparinization. And because FMD patients might have more reactive arteries, some pre-medicate with nifedipine and often infuse nitroglycerin directly into the renal artery to counter spasm.
And imaging during the procedure.
Definitely. An aortogram first, then selective shots of the renal artery from different angles. Pressure measurements across the lesion are common too.
What if the branches are involved?
Might need multiple wires, maybe kissing balloons in adjacent branches, but often just treating the main artery stenosis is enough.
How do they choose the balloon size?
Based on the estimated normal diameter of the artery, from pre-procedure scans or measurements during the procedure using IVUS or OCT. They start appropriately sized and may incrementally increase it.
And if it hurts?
Pain during inflation or any complication means stop. Cutting balloons aren't usually first line due to rupture risk, but if used, start undersized. IVUS or CT can help differentiate FMD from hypoplasia, a thin-walled, small artery which has a higher rupture risk.
What about stents? Are they common in renal FMD PTRA?
Actually, no. Stents are typically not needed. Balloon angioplasty alone often works very well, breaking the septa and stretching the wall.
Why avoid them?
Higher rates of restenosis than narrowing coming back inside the stent have been reported. Plus, you're putting a permanent implant in often young patients, which could complicate future surgery if ever needed.
So when would a stent be used?
Really only for specific situations. Managing a severe complication like a dissection during a PTRA, getting a suboptimal result from ballooning alone with a persistent pressure gradient, or maybe treating small renal artery aneurysms alongside the stenosis.
What are the risks? What complications can occur during PTRA for FMD?
The most common is just a hematoma at the groin puncture site, though less so with smaller access techniques.
What about the artery itself?
Renal artery dissection, a tear is rare if the balloon isn't oversized. Most are minor, heal on their own, or with prolonged balloon inflation. Big flow-limiting dissections might need stenting.
And rupture.
Also uncommon, especially the typical medial FMD types, more likely in complex stenosis. May need prolonged ballooning, stents, covered stents, or even emergency surgery.
What about blocking off a branch artery?
Can happen, usually related to guide wire issues or dissection near the branch origin. Occurs in a small percentage, but long-term outcomes are often okay. It really highlights the need for experienced centers equipped to handle complications.
How well do patients do after PTRA? What are the outcomes?
They're generally very favorable, especially for FMD in the main renal artery. Lots of studies show good results over follow-up periods from months to years.
What if branches are involved?
PTRA can often still be done, but the blood pressure response might be less dramatic, and long-term durability perhaps not quite as good as for main artery lesions alone.
Is it easy to compare studies?
Not always. Different patient selection, follow-up lengths, and definitions of cure or improvement make direct comparisons tricky. One big review suggested cure rates might be lower in older patients and have declined over time, maybe due to stricter definitions now.
Does the narrowing come back often? Restenosis?
Re-narrowing needing a second PTRA happens in a fair number, maybe up to a third in some series, but is often clinically silent, doesn't cause problems. Unifocal lesions might have better cure rates than multifocal.
So follow-up imaging isn't always needed.
Repeat angiography isn't routine unless the first result was suboptimal or branches were treated. For classic string of beads with a good initial PTRA result, long-term durability is pretty good. More complex cases might need more re-interventions.
How are patients monitored long-term?
Surveillance with renal artery duplex ultrasound is recommended, usually soon after PTRA, then maybe every 6 months for 2 years, then yearly. More frequent checks if BP climbs or kidney function drops unexpectedly.
When does open surgery come into play for renal FMD?
It's much less common now, usually reserved for severe PTRA complications that can't be fixed endovascularly, like thrombosis, perforation, major dissection. Stents might be an option there too. Also considered after multiple PTRA failures or for large aneurysms, and it's still a key option in complex pediatric cases.
What surgical techniques are used?
Aortorenal bypass is a common one, though FMD lesions are typically more distal than the ostial lesions often seen in atherosclerosis. So in situ repairs are frequent.
What kind of grafts are used?
Autologous vein, the patient's own saphenous vein, is preferred in adults. In kids, the hypogastric artery is often favored and can be used in adults too, especially for complex branch reconstructions. Synthetic grafts aren't usually the first choice.
Other techniques?
Careful handling, ensuring kidney protection during clamping with mannitol, wide anastomose. For aneurysms, simple closure isn't enough. You usually need graft interposition.
What about autotransplantation, taking the kidney out to fix it?
That's reserved for very complex situations, reoperations, failed endo rescue, extensive multi-segment disease, maybe a single kidney with multiple problems. It involves removing the kidney, repairing it on the bench with cold perfusion, and reimplanting it in the pelvis.
How effective is surgery? What are the results?
Early outcomes are generally excellent. But similar to PTRA, reported long-term cure rates might seem lower recently. Again, likely reflects treating older, more complex patients now, as PPRA handles the simpler cases. Failure rates depend on complexity. Kidney loss is rare.
What about surgical complications?
Fatal outcomes are rare in adults. Morbidity is around 19–28%, mostly minor things like UTIs, pneumonia. Early graft blockage can happen, maybe 4–13%, more common with vein grafts or small arteries. Late restenosis is less common now. Renal failure is uncommon. Need for redo surgery depends on the initial problem.
We've taught stenosis, but what about aneurysms alongside FMD? How common are they?
Quite common. Many string of beads patients have small aneurysmal bits between stenosis. Larger macroaneurysms are seen too, maybe in 5–10% of renal FMD patients.
Are they dangerous? Do they rupture?
Rupture risk seems low for most FMD-related renal artery aneurysms. Actual ruptures are rarely reported. How to manage small ones, say 1 to 2 centimeters, a debated observation might be okay. But larger ones, over 2 centimeters, probably warrant treatment. They're also seen in kids undergoing FMD surgery.
Can they be treated endovascularly?
Experience is limited. Small ones might shrink after PTRA of nearby stenosis. Embolization or stent grafts have been used with some success.
Let's shift to kids specifically. Renal artery stenosis in children.
A major cause of pediatric hypertension after aortic coarctation and kidney disease itself. Can be FMD, but also other developmental issues, NF1, Takayasu, etc. often associated with wider vascular problems like mid-aortic syndrome.
Can kids get PTRA?
Yes, technical success is high, often over 80% cure or improvement. But kids' arteries are more prone to spasm. Metroglycerin helps. String of beads is less common. There's more recoil after ballooning, so caution with sizing is needed, especially differentiating dysplasia from hypoplasia.
How are long-term PTRA outcomes in kids?
Variable. Restenosis can occur in up to a third. Close follow-up is crucial, especially for complex cases. Multisegmental disease has a higher PTRA failure rate. It's encouraging, but needs careful comparison with surgery. Treatment should be centralized. Sometimes partial improvement with PTRA allows delaying surgery until the child is older.
What about open surgery in children?
A higher proportion have osteolesions. Direct aorta to renal artery connection is preferred if possible. If bypass is needed, arterial allografts, like internal iliac, are often recommended over saphenous vein due to concerns about aneurysm formation in vein grafts in kids.
Outcomes of pediatric surgery.
Excellent long-term results. Low mortality, low risk of needing dialysis later, minimal restenosis despite growth, but again, needs highly specialized centers.
Okay, let's move up from the kidneys to the neck, the extracranial cerebrovascular arteries, carotid and vertebral FMD.
Right. We often focus on renal, but the U.S. registry shows carotid vertebral involvement is nearly as frequent, primarily middle-aged women again, and often linked with brain aneurysms or renal FMD.
How common is it? Do we know the prevalence?
Not precisely in the general population. Studies based on imaging series give estimates from maybe 0.4% up to 3–4% in specific surgical cohorts, often bilateral, 35–85% of cases, same demographic, women 40–60 mostly, rare in African Americans. And remember, finding it here means you should look elsewhere too.
How does carotid FMD cause problems? Strokes, TIAs?
Same basic issues. Narrowing reduces flow. The abnormal surface can be a source for emboli clots breaking off and going to the brain. Dissection is another major complication, tear in the wall causing stenosis, aneurysm, or rarely rupture. These complications happen in less than 10%.
Is it mostly the string of beads type here, too?
Yes. Medial fibroplasia causing string of beads is most common in the internal carotid, maybe 80–95%. Typically affects segments higher up the neck than atherosclerosis, sparing the bifurcation. The artery can also be elongated, tortuous, even kinked.
What other vascular issues often coexist with carotid FMD?
Quite a few. Atherosclerosis at the bifurcation can be present. Extracranial carotid aneurysms occur in a significant minority. Carotid dissection is relatively common. Vertebral artery FMD is often seen alongside carotid FMD.
And intracranial aneurysms.
Yes, found in at least 10% of all FMD patients, maybe up to 50% of those with carotid FMD. Often on the same side as the carotid FMD, and they carry their own rupture risk. Renal FMD coexistence is common too, and that carotid web variant is linked to embolic stroke.
What's the natural history? Does asymptomatic carotid FMD usually stay quiet?
Not fully understood. We know it can cause symptoms. Studies of incidentally found cases suggest a low rate of future events, and most asymptomatic patients remain so. But angiographic progression is seen in about a third. We lack good data on asymptomatic severe stenosis, where risk might be higher, and there's no perfect non-invasive follow-up method.
How does it usually present? What symptoms bring people in?
Can be incidental, or it can cause TIAs, strokes. Stroke is the first sign in maybe 12–27%. TIAs, hemispheric symptoms, or amaurosis fugax, temporary vision loss, are common presentations.
What about physical exam findings?
Maybe Horner syndrome, cranial nerve issues, focal deficits. A carotid brood is heard in about a third, but it's not very sensitive for FMD.
Any non-specific symptoms?
Yes, things like dizziness, persistent headaches, pulsatile tinnitus, neck pain, swooshing sounds. These should trigger evaluation, especially in younger patients without atherosclerosis risk factors. More focal symptoms usually mean severe stenosis, emboli, dissection, or aneurysm issues.
How is it diagnosed then?
Often starts with carotid duplex ultrasound for a brood or vague symptoms, but ultrasound can miss distal lesions where FMD often occurs.
So angiography is better?
Traditional arteriography is excellent for anatomy. CTA is increasingly used. MRA is less useful for initial diagnosis due to signal dropout issues, but might be okay for follow-up. Important to also image intracranially for aneurysms and check the other side. Brain CT MRI looks for stroke aneurysms.
How is carotid FMD treated?
Asymptomatic patients usually get medical monitoring and antiplatelet therapy like aspirin. No clear role for statins unless they also have high cholesterol atherosclerosis.
What about symptomatic patients?
Symptoms usually warrant intervention, typically dilation. If there's focal cerebral ischemia, TIA, stroke related to the stenosis, mechanical repair is generally recommended.
Are there specific challenges in treating carotid FMD?
Several. We can't reliably grade stenosis severity like an atherosclerosis, complicating assessment and follow-up. If both FMD and plaque are present, figuring out the culprit lesion is hard. Managing contralateral asymptomatic lesions is tricky. Indications for intervention with non-focal symptoms are ambiguous, and coexisting brain aneurysms or renal FMD hypertension add complexity.
So when is intervention definitely considered?
For focal ischemic events or clear hypoperfusion symptoms, PTA balloon angioplasty has worked well in renal FMD. For carotid, angioplasty, often with stenting nowadays, is common for atherosclerosis, but results specifically for FMD are less certain.
What approach is preferred for angioplasty?
Balloon angioplasty is the mainstay. Can be done via open transcervical access with clamping and flow reversal like TCAR or percutaneously from the groin, ideally with cerebral protection.
Cerebral protection is important. Why?
Because FMD lesions are often web-like with debris. Disrupting them can cause emboli, so yes, protection is needed. But FMD often extends distally, making filter placement tricky. Flow reversal might be better in those cases.
Are stents always used with carotid angioplasty for FMD?
It's debatable. Not usually needed in renal FMD PTA. Used routinely in atherosclerotic carotid stenting, maybe help stabilize tissue, but limited experience specifically for FMD. More data needed, especially given younger patients and unknown long-term stent performance, may be considered for dissections.
What's the role of medical management?
Antiplatelets for asymptomatic patients. Rule out other artery issues. Treat associated aneurysms, RAS. Manage dissection stroke as usual. Regular imaging follow-up, DUS, CTA, MRA every 6 months. Consider repair if symptoms develop or lesion changes significantly. No proven role for anticoagulants, anti-inflammatories. Avoid neck manipulation, whiplash, sports.
And the actual mechanical repair options?
Historically, open surgical graduated rigid dilation. Now, more commonly, balloon angioplasty via either open access, common carotid, often with TCR flow reversal, or transfemoral percutaneous access with cerebral protection. TCR approach is often seen as optimal currently. Surgery endovascular options for associated aneurysms too.
Tell me more about the techniques.
Open dilation involves passing metal dilators gently. Balloon angioplasty needs careful wire passage, appropriate balloon sizing, usually slightly undersized first, and meticulous technique. Avoid angioplasty in clearly aneurysmal segments. Open repair is better there. Stenting, if done, usually uses self-expanding stents sized appropriately, minimal length, avoiding stiffening or kinking. Results data is still limited, but procedural complications seem rare in expert hands.
We've covered renal and carotid extensively. What about FMD elsewhere?
Remember, it's systemic. Can show up in lower limb arteries like the iliac's, often asymptomatic, but can cause claudication. Visceral arteries too, usually multiple vessels, often asymptomatic due to collaterals. Mesenteric ischemia is rare.
Coronary arteries?
Rarely reported, but strong female link. Associated with SCAD, spontaneous coronary artery dissection. SCAD is seen in maybe 1% of heart attacks, but much higher in women under 50, especially postpartum. Coronary FMD usually looks like a long, smooth, distal narrowing, not typically a string of beads.
Wow. That's a really thorough overview of fibromuscular dysplasia. From its discovery to the complexities of diagnosis and treatment across different arteries, it's definitely more involved and potentially more common than many might realize.
Absolutely. Its multifaceted nature, the diagnostic hurdles, the range of treatments depending on where it is and how severe. It really highlights why we need to think about FMD, especially in younger folks with hypertension or cerebrovascular symptoms, even though it was once considered so rare.
Which brings us to our final thought for you, the listener. With research ongoing into the genetics of FMD and seeing this incredibly wide spectrum of how it presents, what might the future hold? Could we see better, earlier diagnostic tools, maybe more personalized treatment strategies down the line? Definitely something to ponder.
And as always, we encourage you to look at the source material in Rutherford's for more detail. And of course, if you have personal health concerns about any of this, please do consult with your own medical professionals.